All right, let me give you some physics perspective of the treatment that we're discussing today, which is very exciting and has a very long history. And this is actually, the initial idea came from Tom Fogarty, who's the inventor of many catheters, in 2001, actually, for the treatment of atrial fibrillation. And in 2006, the company CyberKnife was created. And we initially evaluated basically atrial fibrillation in animal models at the time. And this is me discussing with Tom Fogarty back then, what we want to target and how we approach this method. That was very exciting times back in 2008. So unfortunately, we ran out of money. We kind of burned about 16 million just on animal studies. That was very exciting on the research level, but not much on the venture capital level. And finally, the company and all its patents were bought by Varian in 2018. So my disclosures, basically, I've been an employee of CyberKnife from 2008 to 2010, but otherwise I have no disclosures. So Judith already pinched this. So we published a review of the technology and procedures and future opportunities on STAR. And basically what we have initially, we have electrophysiology information from various systems, Cardio or Navex or, Cardio Insight. There's a lot of systems that can be used here. And additionally, you might use PET scans or MR, for anatomical scar imaging, and combine everything basically to generate the target structure. Okay, well, I'll show you that in a little bit more detail. Then you have the motion analysis, and it becomes very tricky for radiotherapy because you have cardiac motion and respiratory motion on top of each other. So that's very tricky. We'll address that. You have your choice of motion management. Then you basically have your planning imaging that you know from stereotactic body radiotherapy. You have your PTV expansion, you have your prescription, and I will also show you about the dose and what it's like. And then you have your treatment planning, your patient-specific QA, patient positioning, treatment localization, and dose delivery. So the lower parts are actually fairly straightforward and the same as you would do a long SBRT case. So let's have a look at the dose response relationship first, then we go into some target definition, motion management, treatment planning, and some treatment examples. So when we talk about the early works from CyberKnife, sometimes they publish 25 gray works and 25 gray does not work. So basically, from all the experiments that we did in the last 15 years, we can pretty much conclude that everything below 30 gray will not create a scar. And everything above 30 gray is single fraction. Multiple fractions hasn't been tried. So a single fraction of 35 gray will lead to fibrotic lesions in the heart. And, you can treat block of electrical signals with that. So you see here an electrical block at the isthmus on the right atrium. And here you see actually on the right side, the cardomass for it. So that was very early. We treated everything from AV node to the left ventricle, to the left atrium, right atrium. We treated everything just to test out what's possible. Back then, after 2010, I went back to Germany to continue my research on an animal study, and we did basically a dose response study here, treatment planning on the same day. It's an 8-hour procedure, basically with the LINAC treatment, standard LINAC treatment. And then we had 6 months later on follow-up on various dose levels from 15 to basically 40 gray and 2.5 gray steps. And we just wanted to see, what the effects are. And let me show you. And that has been, reproduced now in the last years also. So we have 25 gray, single fraction, doesn't do much. Also on the cardiology side, on the electrical side, there's not much damage that you can see here. With 32.5 gray, you see some scarring here denoted in gray and red. But no transmural scar that you can see. But with 40 gray, you see very nice transmural scarring. and fibrosis after 6 months of treatment. So we have established a pathology for STAR, and we can see here a very nice block in the right superior pulmonary vein of the animal model. Here a pig model, and here you have some basically histology slides. So this is a regular structure. This is some mild fibrosis, and this is 25 gray. And note that most of the treatments for VT have been done with 25 gray. So you see only some mild fibrosis with 25 gray. You see some intermediate and moderate fibrosis on 30 gray. Here denoted in blue. And then with 32.5 gray, you see a larger fibrosis. And with 40 gray, you see basically a complete stenosis after 6 months. So, complete fibrosis, and even with stenosis in the vein. So that's what we don't want, of course. So we did all the analysis, and we can pretty much say that you need about 30 gray to get or more than 30 gray to get really fibrosis. But the question is, do you need fibrosis? That's very important. Or are there any other effects also? And we published that already in 2013 and 14. And the same was noted with not with just photons. So we did 6 MV photons. The same it was noted was with protons or heavy ions. So basically the same dose response. And very nicely, a group from Korea has just published, with 35 gray or 32.5 gray actually, a very nice block here for atrial fibrillation, pulmonary vein isolation model with the dose that we suggested would be useful, and they really reproduced that on an anterior posterior lesion set. So you can really create a lesion with that dose. Now the question is, and we all know these publications from in the New England Journal with only 5 patients, that was very exciting back in 2018. So why did 25 gray work? With a significant reduction in VT episodes, a number of ICDs shock 0 and even down to 0 on these 5 patients. And the pacing from the ICD even went to 0 in very short time. But they treated only with 25 gray, so no fibrosis that they created. So we know fibrosis with doses over 30 gray, and there was this really nice group in Korea that published that, and you did also pinch that earlier. So basically, we have some swelling here. We have vacuolization from intermediate doses between 20 and 30 gray, basically. So we have these swelling, and basically this might be the case that in a damaged heart, you can see immediate effect. Actually, there's reports on effects on the same day, which is, for radiation oncology, very, very strange to see a same day effect. But these mechanisms that they published basically seem to be the key effect of the 25 gray delivery. So a functional dose that we see here. And this is very important to understand also for the long-term effects, because in some series, we now see some late recurrences after 25 gray because of the lack of creating a scar with less than 30 gray. Okay, now we have kind of established that, and we're still in the process. This paper was just published 2 months ago, so we are very, very early in the stages of understanding the real mechanisms of what we actually do there, which is kind of interesting. We are 15 years out on research, and we have not really understood the mechanisms of what we actually do, which is kind of interesting. So, let's go to target definition. Judith has shown quite a number already. So for atrial fibrillation, we want to isolate the pulmonary veins, which is here, basically these 2 targets, or we can actually isolate the whole atrium as well, which has been done in a couple of patients. Actually, there have been 5 patients worldwide treated only for atrial fibrillation. So this is how it looks like. So you can either do like an anterior lesion set or like a pulmonary vein lesion set, but you can also see here the esophagus in the middle and the bronchial tree, which is really a tricky target for that kind of procedure. And remember, you really need to have higher doses than 30 gray here to create a block. So this is really what we went for with CyberHeart back in the days. And VT was not really our main interest because the money, as you say, it was a venture capital company in California, CyberHeart, and we were really into atrial fibrillation. But it has turned out that, you know, for VT, it's much better use, and the patients will benefit much better from that. So let's have a look at target definition for VT, and Judith has presented that already. There's different ideas on, you know, locating the clinical VT of treating basically the whole substrate. And there was some question in the chat, you know, of treating the border zones and such. So that's very unknown. And if you present that that idea, or, you know, like a map, electrophysiology map, to 5 different cardiologists, they will treat 5 different things, which is really interesting to see. And makes it really hard to reproduce. And as you can see here in our paper, we showed that very clearly. And even in the guidelines that have been published, it's really not clear what is the goal, what you should treat, which is really tricky to understand. And we are really at the beginning to understand that. There's some help which you can do, the 17-segment model that Judith has presented. There's software now that can basically map that to a contrast CT, which really helps you narrowing down what you want to treat. But in the end, your target might be a little bit larger than you think it is, and including motion and everything. So we're really treating a lot of cardiac tissue, which is scary, but it works, interestingly, and the toxicity is not very high. So there are some other workflows that have been published, and you did show that already, with integrating the cardiac system, so Carto or NAVEX or Rhythmia maps, or even Cardio Insight onto the planning CT, which is the ultimate thing you want to do. We want to see basically the cardiology information here. But also, you know, about deformable image registration, we're not even there yet. We really try to only import the data first to these systems. They're very incompatible. You know, cardiology and radiation oncology have not talked to each other ever. You know, they're only starting to understand, okay, so we think we need to do something here. But in the next 5 to 10 years, that will be really interesting to see this integrating in the treatment planning systems that we have. So now coming to motion management, after we defined the target, it was some magic and some software that is out there these days. And really, you need to sit down, the cardiologist, the radiation oncologist, and the medical physicist needs to sit down and understand what they want to treat, how it's mapped into the different systems. And really, you need to have a lot of time of, you know, going through these systems and mechanisms that have been also published. So motion management for STAR is pretty similar to actually motion management in SBRT. And we published, last year, we published our technology quality requirements, and we stated basically that you need to do some systematic assessment and consistent consideration of periodic and non-periodic target motion during basically everything from imaging to target volume definition, dose simulation, everything. And there's certain techniques that you can use, like breath hold, free breathing with gated beam delivery, free breathing with continuous beam delivery using an ITV approach, mid-ventilation concept, or free breathing with dynamic tumor tracking. So these are all well known with all different systems that are out there. And what we actually only add, and this is again our cardiac review paper on the technical side, what you add is a cardiac motion component on top of the respiratory motion component, which you cannot compensate, not yet. Or maybe you can. There's even some discussion about that, and I will show you in a minute. So basically, you have some breath hold techniques, you have some gated delivery techniques on the respiratory side, and then you need to address the cardiac motion, basically tracking the cardiac motion, which is not possible yet, rather an ITV approach, you know, compensating the cardiac motion. Or in combined ITV approach or direct tracking plus ITV approach, or complete direct tracking, which is kind of the ultimate goal we all want to go to, but that will take a number of years to actually do that. However, let's have a look at the motion first. So for atrial fibrillation, we have some motion in the range of 5 millimeters in different directions. So that has been, published in a couple of papers now. So we only see 5 millimeter motion. Okay, so 5 millimeter, maybe it's not that much. And if we look at ventricular tachycardia motion, and this has been published by a group from Cleveland, they also only find like 2 to 3 to 4 millimeter motion. And remember, these patients are really they had a scar tissue in the heart, so basically an infarct, and this infarct zone that we're treating is actually not moving much with cardiac motion due to the infarct. There's not really much live tissue there. So overall, we see again 5 millimeter motion. So the question is, and then they concluded that like 90% of the cases they looked at are less than 5 millimeter motion. So for respiratory motion, we see quite a difference. There's about a centimeter, and especially if you don't do motion compression with an abdominal compression, if you do free breathing, you see even up to 2 centimeter motion. So you really need to address the respiratory motion, but do you need to address the cardiac motion? That's the big question. And we've done some studies back in the days. So this is the concept that we did initially, like tracking the respiratory motion, compensating the cardiac motion with an ITV envelope, creating a margin. But what we did is we tested that in phantoms. And we found out, so this is basically the dose curve that you see here in the target area when you don't compensate anything. So you see like a significant drop, and that this is when you don't compensate only the cardiac motion. It doesn't look really different because what we need, or what we saw here in various experiments, is that when you have cardiac motion of less than 1 centimeter, the dosimetry effects are pretty much zero, or not negligible. So 1 centimeter motion, which we hardly see in the targets that we treat, will create only minor effects on the dose side, which is really interesting because you have these fast pulsating motion, and when you treat that, really the dosimetry effects are really low. So maybe we don't really need to take care of that cardiac motion. Maybe we don't really need to be scared of that. And we have shown that in numerous publications now on the phantom studies. So how can we track the respiratory motion? We have basically in the CyberKnife, and there was some question in the chat, most patients have an ICD implanted, and the ICD tips that are screwed into the ventricle or in the coronary sinus or wherever they are, you can track those electrodes. And we did numerous testings back in 2008 on various catheter tips and pacemaker lead tips and everything. And the CyberKnife system actually works pretty well on this. And the group in Ostrava, they treated about 30 patients by now, all treating with the CyberKnife and all tracking these electrodes, which is really, really nice and gives you nice feedback. And also when you do Linac-based treatments, and this is the group from St. Louis, they have checked their motion, actually cardiac motion and respiratory motion, you see is not really that high. And they compared the motion between abdominal compression and free breathing ITV approaches in their patients. And you see the difference is really not high. So they see motion only of 5 millimeters, respiratory motion, and either with free breathing or with abdominal compression. And they could really also use with this cone-beam CT, they use the leads as well, the ICD leads for registration during treatment. And this is really interesting because we might actually not be really scared at all about that motion we have. Of course, there are patients that will move quite a bit. But most of the patients, when you do a very good setup, as you do on lung SBRT, you will be able to treat these patients also for STAR. But of course, we can go one step further, and this is more into research now. We can do 5D dose calculation. So not only just looking into 4D of integrating the respiratory motion component, but also integrating the cardiac motion component. And this is what we did in our animal studies back in 2014. So basically the black line is the original planned dose. And here you see only the cardiac motion component is very small that you see here really. When you reduce that basically for the cardiac dose calculation, then for the respiratory dose calculation, and this is the larger motion here in these animals. And when you combine the two, then you get the realistic dose calculation, which is really nice. But again, the cardiac motion itself is not really the biggest issue that we have here. Good dose, a good motion compensation for respiratory motion, you will be able to treat those. Now, can we do everything? Can we track even the cardiac motion? Yeah, we can. There's a group in Vancouver that did that. They actually gated the beam for the respiratory, for the cardiac signal, including the respiratory signal. And so if you're interested, I can refer you to that paper from Justin Poon. And they even demonstrated that they can treat it statically and with a gated delivery based on the cardiac ECG signal. So that's really interesting, but the question is, do we really need that? So I'm not 100% sure we do. It's nice if it works in the future, but I don't think we really do. I think we treat most of our cases are really low motion there on the cardiac side. So going forward to treatment planning, there's a lot of dose limits that have been published, and also within our Reventa trial, we have published these dose limits. And it took a long time with our authorities also to go over them and to check. And mostly the biggest problem is we don't know about internal cardiac structures or substructures. So we can really only give some dose recommendations. Some limitations for the coronary arteries, which is a bit sketchy. So these are sometimes in the target or near the target. So, you know, there is some variability that we still have to learn on the coronary arteries, what dose we can give. The order is pretty straightforward, as we know the dose limits there from a lung SBRT. But also nicely, and I can only refer to the Knudsen paper, there's a subgroup or as a sub-analysis of the dosimetric analysis of cardiac substructures from their clinical trial patients, which is 19 patients for STAR. So they really have evaluated that, and I think we will learn a lot more on the cardiac substructures in the near future. But otherwise, we can only do recommendations other than the coronaries, which is still a little bit in limbo, as I said. Now, externally, it's pretty straightforward. There's a lot of data out there that we know from single fraction treatments. And actually, these are for VT patients that's mostly far away, but some cases are near the stomach. So we have to be careful there. And for ICDs, well, so the electrodes are fine. There are not really any issues with treating the electrons with those. But the electronics in the chest that you have to block basically with radiation. You should really make sure that below 0.5 gray is received by the major electronics there on the chest. And there's a nice report of the APM TG203 about that dose and management of these patients. And that's also reason we only treat with 6 MV, because if you go higher, you may get interference between the ICDs and basically the linear accelerators and the system. So we really try to keep them at 6 MV, and for our Reventa trial, we only allow 6 MV treatment, and with that, you're actually pretty fine. So treatment plan for AFib, we've published a number of patients. A number of publications now, and really for atrial fibrillation is really tricky to treat that with 30 gray or higher right next to the esophagus. This is really something that is probably not going to be a very safe procedure in the future or effective. There are some treatments, but the results are very limited. So it has been proven as very risky, very tricky to treat. We have published that, also trying to look at MRI Linacs or at protons or heavy ions. That might be some future, but really I don't see that treatment being mainstream in the near future because of that problem that we really need to have more than 30 gray to block the electrical signals. And what we don't need to do in ventricular tachycardia. This is some work. So we have looked at numerous treatment planning benchmarks. And really, we came to the same conclusion that every system today can treat everything. So there's some benefit of, CyberKnife versus Linux-based or VMAT-based systems, but really in the end, they can all do the same if you have a good user using them. And we've seen the same basically here, some 3 VMAT cases and 3 CyberKnife cases. So there's some good CyberKnife cases, some good VMAT cases for VT that you can use. But again, it depends all on the user, and the systems can create the same dose as you can see here, like in case 3, the Riva, here or the aorta, or even here the left ventricle or right ventricle dose. You get all pretty much the same doses with all systems that you can use. So really, from the treatment planning perspective, you have your dose limits. You want to have 25 gray. You maybe want to have some inhomogeneity in your target, which is unclear. Do you want to treat 25 gray at 80% isodose, or maybe go lower and have some more high dose in the real target to create long-term scar? That is really unclear. We don't know. We're at the beginning there. But otherwise, it's pretty straightforward and pretty much the same as you do in lung SBRT. Can you do protons? Yes, there are some studies with protons, and protons do better. Maybe it's basically the same questions that we have for any other indication at the moment. And of course, this will be investigated, and we will see. We will see where that leads. So coming to treatment, just give you some examples, and this is again from our review, and I really encourage you to read that. So there have been treatments with CyberKnife, all 25 gray in single fraction. They did all basically fiducial tracking with an ICD lead, so that works pretty well. And some use, an ITV-based motion management on the cardiac side on top. And otherwise just a simple CyberKnife system. But you see on the treatment times, 90 minutes, 120 minutes. And there is some reports that delivering 25 gray in 90 minutes is something very different than 25 gray in 10 minutes, which is possible with linear accelerators, with Xeon linear accelerators, which we see here. There's a lot more treatments done, also 25 gray in single fraction mostly. And there's some treatment planning margins, ITV approaches, some motion compression, but mostly ITV and motion compression wherever possible. So no gating, no tracking, nothing at that, what we find in the literature. But very fast treatments, 4 minutes, 5 minutes, 14 minutes. And maybe that's also the reason why we see some differences between CyberKnife and between standard LINAC efficacy. So we really see some difference there, but we need more data to be conclusive. I personally think that with the accuracy you have on the CyberKnife, you will lose with the treatment time, and then you lose efficacy, because we're not treating tumor, we're treating basically healthy cardiac tissue, which will heal during that process. And we know from Jack Fowler, which we talked a lot to back then, that treatment of 90 minutes is very different than a treatment of 4 or 5 minutes. So here's some examples. So CyberKnife, this was a case that we treated in our center in Germany, a patient with an aneurysm here on the lower part, and we really wanted to have the accuracy, because right below, you can see that here in the lower corner, is the stomach. So we really, really wanted to have a good treatment accuracy here. But the treatment, again, as I said, took 90 minutes. Here you see the tip of the catheter. Actually, we have some motion that you can see here, unfortunately, some motion blurring, and a second tip. But using the tip for treatment was very easy to do. You have these motion modeling here. You see some errors in the motion modeling. Why is that? Because you see the cardiac component on top as correlation error. The CyberKnife system can only compensate the respiratory motion, and the correlation error that you see here is basically the cardiac component. But the treatment accuracy is still below 3 millimeter, which is really nice. However, again, long treatment. And these are just some examples. This is the guy with the big heart, this is a cardiologist, the therapist beaming, the radiation oncologist is basically down here. This is Professor Schweikart, who is one of the initial inventors of the CyberKnife. And this is our first CyberKnife treatment in Germany on VT. We also did that with TrueBeam. A very fragile patient could not lay down more than 30 minutes, so not possible with CyberKnife. We did an ITV concept based on 4D CT, a 5mm margin. We also included an ITV, somewhat a small ITV for the cardiac motion. We did 4 dynamic conformal arcs, very fast treatment, and in between 2 arcs, we did basically we did another CVCT for setup. And this is the patient here, and you see we have ECG monitoring during treatment, and we check basically the collision here, and then we treat him 10 minutes from start alignment to basically finish of the treatment. And here you see not Corona, before Corona, of course. Here you see the team that's needed for treatment, and we have many physicists here. We have many clinicians here, therapists, and the boss on the left-hand side, and the cardiologist. We have 2 cardiologists on standby should anything happen to the patient during treatment. So that's really important to have a cardiologist on standby as well during treatment and doing the ECG monitoring in room. And this is another example, Judith. I'm sorry that this was performed by the best deep inspiration breath hold team in the world. This was done by Judith in Mannheim using the Versa HD and deep inspiration breath hold and catalyst with gating. We're very ambitious, very precise treatment that we published together. Also, that the precision is very similar to CyberKnife. So this can be also done if you have a great team and doing the setup. So Judith very here a compliment to this treatment, which I think could be actually the first in the world that has been performed this way. And then we have MR Linac. This has been published from the Zurich group. They also treated on an MR Linac. They did extensive testing at the beginning. I'm not really happy to have patients with pacemaker, and this case was actually with a pacemaker that was not allowed, was not MR usable. So they really treated this patient with ICD off. We generally treat with ICD on during treatment. So that's very tricky. And they treated not the heart, but they treated a substructure here. Very ambitious, but successful treatment. Very nice that they did. And last example, they treated with Protons here in Italy. That was recently published by this group. And so you can do it too. And there's actually been 1 or 2 patients being treated with heavy ions in Heidelberg now. So every system can be used. You shouldn't be scared. Should you do it for all cases? Probably not, but it's very interesting that you can basically use every system that's out there. So we still have a lot to do. And as Judith said, there's StopStorm. And in StopStorm, we're trying to come up with a certain way of harmonizing this treatment, which is really, really tricky to do, especially on the target definition side. And then we're trying to have build up a registry in Europe, but it's not limited to Europe, which is really nice. So we can also include centers from around the world, for example, India, which is really a really nice thing. And we can register all our cases in this database and then evaluate that jointly with the metrics that we set up. So, and this will come along with benchmarks, with the quality criteria that we happily give also to new centers to help them along to get started. Thank you very much.